Day to everyone, and I welcome all of you to the 26th webinar of Update in Advanced Hematology. No seminar, no webinar is complete if it is just advanced and there's nothing which tells us about the basics. So today we have two stalwarts in their own areas. A clinician, Dr. Sumeet Bhatia, who is a medical director of Community Health Network, MD Anderson Cancer Center in Indianapolis. It was in 2022 that his practice got affiliated with the renowned MD Anderson Cancer Hospital. He's also the founder and president of Community Hospital, as well as a physician executive oncology. However, he is our own, who has done his undergrad and postgraduate at KEM Hospital in India. His special interest lies in lymphoma leukemias, lung carcinomas, as well as symptom control. The other speaker that we have is Dr. Kunal Sehgal, again, a very well-known consultant hematopathologist and flow cytometrist. He's the director of Sehgal Path Labs. As I always tell Kunal, he's a brand by himself. And he is very, very well known in flow cytometry. He has done his MD pathology from the renowned PGI Chandigarh. He has training in hematopathology and fellowship at Tata Memorial Hospitals. He has received fellowship from John Hopkins Hospital in the US. So both these speakers are going to take us through certain areas of hematology. Let me just tell you that in today's world where there is bidirectional interface, if there is no connect between a clinician and the lab, then we do not say that's a good lab practice or a good clinical practice. And at CAHO, we certainly aim to ensure that any of our webinar gets us both sides of the coin. How a pathologist is necessary for clinical diagnosis and the role of a pathologist to a clinician, they go hand in hand. And today that is what we aim at. So we are going to be starting with Dr. Kunal Sehgal, who is going to take us through. Kunal, your presentation, please. Approach to bone marrow evaluation. Kunal, all yours.
Thank you, ma'am, for the kind introduction. At the outset, I would like to thank Dr. Sumeet Bhatia to join in for this meeting today and thank Aparna and the whole CAHO Diagnostics and the whole CAHO division for giving this opportunity. And as ma'am said, it's one area is hematology where, clinicians and pathologists work very, very closely together and overlap in their role for the benefit of the patient. So in the next 30 minutes, I am going to share my experience on how to approach a bone marrow evaluation. And, we might have questions at the end of the two talks or in between as Dr. Simi will moderate the whole session for us. So moving on, when we talk about bone marrow evaluation, we always first need to know what are the indications of doing a bone marrow. And typically, the most common indications would come from primary bone marrow disorders. They may be any kind of unexplained anemia or cytopenia, or there may be a cytosis. So you may have a hemoglobin low anemia or a polycythemia. You may have a thrombocytopenia or a thrombocytosis. And this may vary from a nutritional anemia to an aplastic anemia to leukemia, MDS, and so on. The other broad category where this marrow examination is done is any staging. This may be for a lymphoma, myeloma, or a round cell tumor. When somebody is suspecting a metastasis into the marrow, investigation of storage disorders, pyrexia of unknown origin, or sometimes when there's an unexplained organomegaly, a lymph node is inaccessible for biopsy. So broadly, these are the various indications where a bone marrow is done. When a bone marrow is done, one needs to understand that this needs to be a comprehensive bone marrow evaluation. You cannot report a bone marrow without a CBC, which should ideally include a peripheral smear and automated retic count. A bone marrow aspirate goes without saying, along with imprint smears, and include the humble iron stain. Do not forget that. Often, the practice in our city and some parts of our country is that aspirate is reported by somebody else and the biopsy and the IHC are done by the histopathologist, and the aspirate may or may be reported by the clinician. But I always recommend that the lab which is reporting aspirate and or biopsy should do both together. In case your department has two separate sub-departments, it should not stop you from seeing the aspirate if you're reporting the biopsy or vice versa. This will always impact because ultimately it's one patient sample. While doing the aspirin biopsy in today's day and age without doing IHC studies, it's an incomplete evaluation. So you'll have IHC for the bone marrow biopsy. And as we go along, I'll show you why IHC becomes critical for biopsy evaluation. And obviously, you have other ancillary techniques for the liquid sample, which is flow cytometry, cytogenetics, FISH, and molecular studies. And we'll discuss more of that as we go along. Uh, Broadly, the most common site where the bone marrow aspirate is done today is the posterior superior iliac spine. Now, some people might prefer the lateral decubitus position or the complete prone position. That's the choice of the person doing the procedure. Now, I would like to emphasize a couple of minutes on the sample collection, because if the sample collected is insufficient, inadequate, or not properly collected, everything goes for a waste. So what we do in our laboratory when I do the procedure or when my clinician colleagues are doing the procedure, what is recommended is we always collect a CBC at the point of at a time point of doing the bone marrow. In our practice, we do the CBC after the procedure is complete. In case the aspirate or the dry tap, in case you required extra EDT or heparin samples from the peripheral blood, you always have the opportunity of collecting that extra sample. So we do it after completing the procedure. While doing the procedure, the bone marrow aspirate smears are made. These are 6 to 10 slides, depending. Ideally, it should be particulate slides. Air dry the slides, air dry the imprint smears which you make from the biopsy. Do not use any form of fixative hairspray solution. This should be simply air dried. Allow them to settle down. If there are particles on the slide, do not put it directly into the box. They need to dry. Otherwise, when you put the slides into the box, the particles will all slide down to one side of the slide. Avoid making squash smears on the bone marrow aspirate. They become a little tricky and difficult for the person reading the slides. And we know making a good slide is also an art. It requires some form of practice, and having a technological staff or a pathologist along with a clinician or somebody to assist you in the marrow procedure is always welcome. Bone marrow biopsy, the longer the better, and we store it in formalin or an AZF solution. AZF is what we use in our laboratory, gives better fixation so that even the IHC processing at the later stage becomes easier. Now, being in a private lab, one of the biggest challenges we face is the transportation of samples. Often the practice in our country is to put this biopsies into these urine-like sterile containers. Often these are not leak-proof containers and they may often leak. And the challenge we face is even the formalin vapor, you may have put the slides into a box, you may have put the slides into a tissue paper wrapped. As long as they are kept in separate containers, separate bags, it is okay. If you keep them in the same bag, the formalin vapor is enough to fix the slides, and these slides will never stay. So what we recommend is collecting the biopsy in a vacutainer or a normal red color plain tube, and that is double sealed, one with the cap and one with the tape around it, so that there's no chance of exposure of formalin or formalin vapor for the samples. Without saying, we almost always collect EDT and heparin sample. Uh, it's ideal to collect one each, if not two each. And this has to be all planned before doing the procedure. If it's a patient of pyrexia of unknown origin, you need more samples to be collected for culture bottles. The culture bottles may be with or without resin, depending upon the exposure of antibiotics. Are you going to do an AFB culture? Are you going to do fungal culture? Are you going to do an aerobic culture? You need to have the bottles ready with you before the procedure. This cannot be done while you are doing the procedure. For flow cytometry, you may use both ETT and or heparin samples. Typically, for molecular studies, you require ETT samples, and for heparin is typically used for karyotyping and FISH studies. So that's the most comprehensive way you can do the kind of testing. Now, moving ahead, as I said, you can do the CBC test. The CBC, in our lab, we've coined the term CBC advanced because we look at various other parameters. The most important part is do a CBC, a peripheral smear evaluation for every case of marrow before heading there. Otherwise, a case of ITP, a case of TTP may look the same on a bone marrow, but a TTP will show you cystocytes on the peripheral smear, which you have grossly missed on the bone marrow aspirate. So your diagnosis becomes totally different. A leukoerythroblastic picture on the peripheral smear will give you a lot more clues to what to suspect and look for in the aspirate. Blindly looking at the aspirate, you may not even think of looking for a metastasis. History often is not complete, which we request organization to send, but sometimes difficult because it may be a surprising element that there is a small cluster of metastasis floating on your aspirate. So a leukoerythroblastic picture, which we had seen on the peripheral blood, will give you a very good clue. Okay, am I looking at fibrosis? Am I looking at an infiltrative disorder? Is it a lymphoma, myeloma? Is there rouleau formation? So the smear becomes very, very critical. Now, this is typically how a set of bone marrow aspirate and imprint smears look like. To the left, two of them are the bone marrow aspirate smears. Typically, you will see that there are some particles. You will see the number etched with a diamond pencil, very critical, because that etching of the number, if you write it in a marker or pencil, disappears and then labeling becomes a problem. Here, typically, we'll etch it with a diamond pencil, and behind what that white sticker which you see here is the name of the patient, the lab ID or the number. And even on the imprints, we are making 3 to 4 good imprints, making the staining the third or the fourth imprint, which is not very bloody, becomes very, very useful. So going on to microscopy, when we look at the bone marrow aspirate, typically we'd want to look at a low power view and then go on to a higher magnification, which is a oil or a 100x lens. At low power, one is typically trying to assess the cellularity, look at the particles, look at the macrocytic number, look for any cluster of abnormal cells. You're looking at the larger cell or a larger population, assessing how the marrow is. Once you go to the higher power, you're looking at lineage assessment. You're looking at the erythroid lineage, myeloid lineage. You're looking at the morphology of the megakaryocytes. You're going to do a differential count and then look at if there's any abnormal cells. So you're looking at individual cytological details and then doing the differential count. Now, typically, we are used to this formula when we assess cellularity. Ideally, this is best done on a biopsy, and assessing on the aspirate is a little risky and can come with experience because the same particle made on a direct smear will look different when you make a particles on the liquid sample, which look a little more empty because all the cells have fallen into the solution. Also, the percentage may vary. So one can assess cellularity nicely on an aspirate, but the confirmation comes typically at this using this formula. So for a 50-year-old person, I would say 100 minus 50, I expect a 50% cellularity. For a 60-year-old, I expect a 40% cellularity. But this formula goes for a toss once you go to the extreme of ages. For an 80-year-old, 20% cellularity is not normal. Beyond the age of 70, this formula is not applicable because any bone marrow to be labeled normal cellular should be 30% or more. It does not mean a 95-year-old should have only 5% cellularity. So the small things need to be kept in mind. And at the extreme of age on the lower side, 1 to 10 years, you will see any cellularity between 80 to 100%, which is okay. Typically, you want to evaluate at least 6 to 8 marrow particles or 6 to 8 marrow spaces, looking at the trails on an aspirate to assess the cellularity. So this is a very broad, low power view. You can nicely see these are the particle fragments. You can see these are the white color fat spaces, and these are stromal regions of the particles which are full of cells. And then you see a stream of cells going out. With an experienced eye, one can start looking at some large cells that are typically the megakaryocytes. To an inexperienced eye, you need to go on a higher power. So we'll go just see examples. This is a child which is a leukemia. This is around, say, a 15-year-old child. You're not seeing a single fat space in this particle. At any age, this is a very packed marrow. This is a very hypercellular marrow with no fat space. Again, an occasional fat space. This is sort of 90% cellular, 95, 98% cellular. So this is hypercellular. Contrast to that, if I said this is a 10-year-old child, you would expect 90% cellularity. Here it is 90% or more fat space. Even the stromal cells over here are all fat cells and spindle cells over here, which you can see on high power. But essentially, there are no cellular marrow material over here. This is a very classic hypocellular particle. Now, that's the way broadly you're looking at cellularity, and you start moving from a low power view. You're looking at the spread of the marrow, and you slowly start picking up these large cells at low power and say these are megakaryocytes. And typically, I would want to say, okay, let's observe the morphology of the megakaryocyte. A normal megakaryocytes will have 3 to 5 lobes. It will be, multi-lobulated, multiple segments coming out of those lobes. What you don't want to see is a lobe separation. What you want to see is 1 to 2 lobes, which is what we call hypolobated. We don't want to see is monolobation. That's a feature of dyspoesis. Often you get asked the question, how do you measure the adequacy? We are typically looking at 1 to 2 megakaryocytes per particle as a minimum to assess the cellularity and adequacy of megs. To call it increase, I like to see focal clustering. If there are multiple clustering of megakaryocytes, like you see in this case, This is the case of myeloproliferative neoplasms. You are seeing a lot of monolobated megakaryocytes and dense clusters. That's typically when we say increased megakaryocytes over there. Now, these are a few examples of what I was talking about as lobe separation. You can see there is complete separation of the lobes here. This is sort of a bilobed or hypolobated. This is sort of a mono or hypolobated meg, a little hypochromatic dyspoetic nuclei. And this is a typical example of a very micromegakaryocyte, between a platelet clump. You hardly barely see any cytoplasm, almost like a bare nuclei. They are the size of a blast or a promyelocyte. And these are what we call micromacrocytes, which you typically see in patients of myeloproliferative neoplasms. Typically, moving from macrocytes, you start then looking at erythropoiesis. Erythroid cells are very nice and round cells. We define them as cells with a round nucleus, with round shaped cell with cytoplasm all around. That's a typical feature on the aspirate. They may also come around the central cell, which is the histiocyte. And we often call this kind of a colony around the histiocyte, this is like a nurse cell, which is nursing and giving the nutrients back to the erythroid cells. The function of the macrophage is eat up the cellular debris and degenerating cells. And once it's eaten up, the stored nutrient which is there, it will start feeding the iron into the erythroid cells. This is not uncommon in a regenerating marrow, especially post-therapy. Please do not call this as hemophagocytosis. We often see a marrow post-induction, and somewhere the patient has fever, had a high ferritin, which is in the range of 3,000-4,000, and then there might be a suspicion of HLH. This should not be labeled as HLH. An example of HLH I have kept. This is an example of histiocyte which contains platelets. It has a neutrophil. Here it has cellular debris. You can see in the background it has platelets, maybe an NRBC. Here you can actually see an RBC and a large platelet ingested. These are classical examples of hemophagocytosis, and once typically it's there, it's quite florid, but this is a nurse cell. In addition to the erythroid, you start looking at the neutrophils, you look at the differential count like a metamyelo, then you're looking at the promyelos, you're looking at some immature erythroid precursors, you're starting doing a differential count. That's what we typically do. I'm not going to details of differential count, but with experience, you start recognizing these are not normal neutrophils. You see, these are bilobe neutrophils. This is also called as pseudopelgarvi. This is almost forming a ring form of a neutrophil. And if you see this erythroid, they are showing budding, irregular nuclear margin, karyorrhexis. These are findings which one sees in dyspoiesis. So when looking at the aspirate, you need to learn what is a normal neutrophil, and then you need to look at what are the dyspoetic neutrophils. Also very beautifully seen on the peripheral smear. These abnormalities get picked up very nicely on a peripheral smear, especially the neutrophil-based abnormalities. Once you have done a differential count on your aspirate, you looked for morphological dyspoiesis. Do not forget the iron stain. It's a gold standard for assessing iron. Iron deficiency anemia is extremely common in our country. Unfortunately, we still end up seeing some marrows for iron deficiency, and we realize the only problem in that patient was an iron deficiency anemia. Megaloblastic anemia is the other challenge which we face when we see marrows. Often both may go hand in hand. Post-transfusion, the iron may appear high. And obviously, one needs to see, along with the iron stores in the particles, one needs to look for ring sideroblast. Again, in private practice, we see a mixed bag. People might feel MDS is most common, but we see mixed bag of patients on AKT, patients on alcohol, patients on alternate therapy, and then the MDS, and then obviously the rare cases of pediatric congenital sideroblastic anemias. So all these kind of things come into practice, but having a standardized iron stain becomes extremely useful to have, and we do this with all our aspirates without fail. Even if we have no particles to assess iron stores, we'll still assess the ring sideroblast, and it often helps. And for example, the last two editions of WHO, you have the criteria for identifying 5% or more ring sideroblast becomes very important because you have an SF3B1 mutation, which is picked by NGS, and this identifies a special good category of MDS with ring sideroblast or associated neoplasms. I'll come to the biopsy, and many of you would have seen this needle. The typical needle was a metallic needle. Jamshedi needle is what we call it. Now we have beautiful disposable needles. They're very, very easy to use. We follow the Hammersmith protocol, which was published by Dr. Hikeri Naresh, and we use the same neutral buffer formula AZF solution typically in this protocol for fixing processing. This article link has been shared with you over here. Again, I like to assess my biopsy at low power, assess the cellularity, assess for clusters, look for granulomas, look for any abnormal mets, look for location of megakaryocytes. Are they normally centered and scattered, or are they abnormally located in the paratrabecular location? Is there any kind of a abnormal histiocyte or a granuloma or a collection there? Once I go into the higher power, which is in a biopsy is typically 40x and not oil, you are looking at again the lineages. You may not be able to do an accurate differential over here, but you get a good idea about the location, the localization of the different lineages, and assessing segmented forms of the myeloid lineages are easy to identify. You want to look at erythropoiesis that is megaloblastic. Identifying megakaryocytes is quite easy, but sometimes micromegakaryocytes or dyspoetic megs can be challenging without IHC. So if I looked at this bone marrow biopsy, the first thing I want to know is cellularity. Okay, and if you were to ballpark, say in this fragment, you would almost say, okay, 40 to 50% fat space, 40 to 50% cellularity. In this fragment, you'll say, okay, almost 60, 70% cellularity, 30% fat space. And this may be again 60 cellularity, 40 fat. So if this was a 55, 60-year-old, I would say, okay, normal cellular. If this was say a 70-year-old, 80-year-old, I would say hypercellular marrow because there is less fat space over here. Now, this is just to give you an idea. This is a case of acute leukemia. The aspirate look packed sheets of cells. When you see the biopsy, zero fat space. So at low power, this is sheeting pattern. There is no fat. This is classical hypercellular, which you see in a leukemia or a high, lymphoma, which is diffusely replacing the marrow. Compared to this, no cellularity at all. What you're seeing is just fat space. This is less than 10% cellularity, classical hypoplastic marrow in a patient of aplastic anemia. You go into the higher power, be careful that you're looking at few cells, and typically in a hypocellular marrow, you have interstitial scattered lymphocytes, plasma cells. You might see a few pink mast cells over there. Sometimes you may see a focal erythroid island. Typically, megakaryocytes are completely absent. Myeloid series mature forms are virtually absent. We'll often do a C34 immunostain because 1 in 100 cases you might pick up a hypoplastic MDS, especially in adults, where hypocellularity is there and you're picking up a few blasts. Now, again, this is assessing cellularity and adequacy. You not only need to have good cellularity, but you need to have adequate marrow spaces. We say, okay, minimum 6 to 8, ideal 10 to 12 bone marrow spaces. And, I would count 1, 2, 3, 4, 5, 6, 7, 8. And I have a second course, around 4 to 5 spaces. I have a good 12 to 15 marrow spaces over here. Very good to assess cellularity. Focal area showing procedural hemorrhage. So this, I would say, is an adequate marrow and representative. But when I come to this marrow, this is showing me only a cartilage, focal crushed cortical bone, a washed off marrow space. We do not label this as hypocellular because you see no cells. This is washed off. You may attempt taking deep serial sections to be sure that there is not a superficial section taken by a technologist. This is another example where, majority of the marrow space is showing procedural hemorrhage. It is possible the aspirate and biopsy was done from the same site. So while doing the procedure, we always remember if you've aspirated from the same site, you need to remove your needle a little bit, take it up, change the position of the hub of the needle again by maybe 2 to 3 mm, and then go to another site. Otherwise, when you go into the high power, all you're seeing is hemorrhage. Again, this is not an hypocellular marrow. If you see some fragments of preserved marrow are seen on the edges, but majority of it is procedural hemorrhage. Then I show you a marrow like this, which actually at low power, if you saw, had 8 to 10 marrow spaces, even on serial sections, all washed off. Nothing there. Maybe one fragment of fat tissue, soft tissue outside of the marrow, but there is no marrow particle, neither fat, no stromal particles, no cellular particles. Again, do not label this as hypocellular. Label this as washed off marrow spaces. Take serial sections, rule out that there is no tissue. I would take step serials or deep serials. Rule out that there is no tissue missed by you. And then, unfortunately, this is an inadequate bone marrow biopsy. There is no other thing. You can either rely on the aspirate or you might end up wanting a repeat procedure. The next thing while assessing a biopsy, be very careful of subcortical tissue. Sometimes you get very good orientation. This is the soft tissue. This is the very good cortical bone, and you see subcortical hypocellular areas. As we grow older, and by the time 60, 70, 80 years of age, those normal 1 to 2 subcortical marrow spaces may become 4 to 6 subcortical marrow spaces, which are hypocellular. And sometimes if you have superficial biopsy, you might see a very good cellular hypercellular aspirate, but the biopsy was a little superficial and 4 to 6 marrow spaces. So you just labeled it as hypocellular. So whenever you have a discrepancy, if you identified subcortical areas, document that this is subcortical and may not be truly representative, especially when you are seeing older patients. So these kind of things are what you need to sort of evaluate broadly, even at low power. Also, the other things which commonly gets missed is looking at the bony trabeculae. We are so focused on looking at the cellular islands that we forget to see the bony changes. Paget's disease, metabolic bone disorders, patients who are having, myelofibrosis can have bony changes. You see osteoblastic reaction around the bone, degeneration of the bone, new bone formation. So again, these are things which one needs to assess as low power and not forget, because every time you may not have the adequate history pointing towards the same. So again, you will assess the individual lineages. You will try to assess the cells. Typically, we know, for example, when you're assessing lymphocytes, you see 10 to 15% in an adult. But how much, sometimes, very often, especially, for example, in females with autoimmune disorders, elderly people with other disorders, you might see lymphoid aggregates. And I'll show you an example. You may see plasma cells. Plasma cells are very innocuous. And in a case suspected of myeloma, any case of MGUS, any case of anemia, without IHC, I will not report plasma cells. That is one thing, uh, visually looks like it's not there. And when you see 138, you will be surprised to see clusters, which even retrospectively becomes very difficult, especially to an untrained eye. With training, you start picking up plasma cells, especially ones which are around the vessels. You see a rimming perivascular accentuation of plasma cells, especially when you do your IHC. So this is an example where you have a nice bony tuberculum, you have good cellular marrow at low power. You are looking at the big cells, which are the megakaryocytes. You are seeing nice spread. There is no stromal edema. There is no degeneration. It looks like a healthy, clean marrow. So you go into higher power and you identify, okay, these are the megs. They are showing normal segmentation. These are nice pad spaces. You're seeing a mixture of erythroid myeloid cells. Again, with experience in a photograph, it's difficult, but what I'm trying to identify is the normally spread, dispersed islands, centrally located erythroid colonies, no paratrabecular hugging of the megakaryocytes. Again, erythroid colonies, they look like bindis, like dots surrounded by cytoplasm all around. Typically, normo to myelomegaloblastic may happen together. So this is an example of an erythroid colony. This is an example of a megakaryocyte. I can point out a few segmented myeloid series cells. So this will be the neutrophils, bands, and the metamyelocytes. You can see nice segmentation. So I know that there's a complete sequential maturation happening. Nice section, so I can even identify a plasma cell, which I'm pointing out with my arrow, and maybe you might pick up some eosinophils, some orangeophilic color over here, pinkish, which you can look at is eosinophils. Again, this is on the aspirate. This is your megaloblastic erythroid series cell, where the nucleocytoma asynchrony is there. And in the same case, I'll show you this is the islands of erythroid colonies. And it's a very nice example where you're having dimorphic maturation. On the right hand side over here, you're seeing the normoblastic mature erythroids, and then adjacent to that is a megaloblastic erythroid colony. They often show, in certain cases of nutritional deficiency, erythroid proliferation, you might start seeing this kind of a dimorphic maturation in the erythroid cells. Again, sometimes difficult when you're in your initial phases of learning, but as you see more and more cases, you can take aid of IHC example CD71 to identify these islands. The challenge is when you have megaloblastic erythroid hyperplasia, they can look very, very conspicuous, the megaloblast. They start showing nucleoli, they can look ghastly, they can mimic an acute leukemia. One clue, typically these megaloblastic anemia cases, when they come, they may have pancytopenia, the biopsy looks ghastly, you have not seen the aspirate. You will say, is this an acute leukemia? IHC is not available. Be very careful, start looking at maturation. Okay, you're seeing neutrophils, you're looking at metamyelocytes, you're seeing good maturation in the background. Start looking at MEGs. If you have adequate MEGs, think, was this erythroid hyperplasia? What was the MCV? Go back to the CBC, go back to the aspirate. You will typically see a lot of megaloblastic erythroid colonies even on the aspirate. They almost always go hand in hand. So correlating this is a must. Otherwise, you'll mimic. In certain cases, you start looking a little ghastly and you will start making mistakes. Every time you see a lymphoid aggregate, do not think of a lymphoma. You see far more benign lymphoid aggregates than lymphomas in the marrow. And it can sometimes become very challenging because we think that this is an aggregate and this is a cluster. The numbers of an aggregate may vary. They may vary from small to large. Sometimes they are very small and circumscribed. Sometimes they have a reactive germinal center in the middle. In IHC, typically, if you do, they show an admixture of T and B cells. And most reactive lymphoid aggregates will show more T than B or almost equal. When it's sheets of B cells with very few T cells, then is when you're starting to worry about, is it a lymphoma? And typically, most B cell lymphomas, in addition to lymphoid aggregate, will show you interstitial spread of B cells also. So those are the kind of things which you need to know. So I said collagen vascular disorders, autoimmune, old age, MDS patients may show, and this is This is not a paratrabecular aggregate. This is close to the trabecula. It is not hugging and sticking to the trabecula over here. And if we did a mixture, IHC, and saw a mixture of 3 and 20 positive reactive cells in the background. At low power, this is something which is not uncommon in our country. And I'm sure all of you will identify Langerhans giant cells, the granulomas, giant cells, epithelioid histiocytes over here. Very uncommon to see in an aspirate. Okay, in so many years of practice, I've seen only once in an aspirate where there's a strong suspicion of miliary TB. That also I was doubtful and confirmed after seeing a biopsy. But biopsy, we see it very frequently. Necrosis, with or without, you may see one. AFB is difficult and challenging to get, and the most common reason is not being able to get 2 micron sections. As Bhatia ma'am always taught me, if you are looking for an AFB stain, if you're looking for a bone marrow biopsy, try and get those thin sections from an experienced histotechnologist, and he or she can give you those 2 micron sections. You will start seeing far more AFB positivity in a bone marrow also come, like you see in other sections. So with that broad overview, I would like to move to a 3-4 cases just to give you a brief of how we see it in practice on a day-to-day things, and just random cases, nothing in order. Some may be rare, some may be common. So this is a 13-year-old girl who was post BLL therapy, but was now having severe persistent anemia, which is not knowing. The clinician did a marrow and said, okay, let's look at what's happening in the marrow. Is there any blast coming out? We had already done the flow MRD, which was negative, and side by side, this was the aspirate in the biopsy. So if you look at the bone marrow aspirate, there's a marked paucity of erythroid series cells. And you had only this large pronoblast, what we sometimes call the Mickey Mouse ears, and you can see beautiful inclusion over here. And even the biopsy in this case, you can see a beautiful inclusion. This is a case of parvovirus. Okay, so the history was there. And sometimes the history may or may not be there, but your eyes should start looking at lineage-wise. If you are not seeing the megakaryocyte, okay, what's happening? If you're not seeing the erythroid, the moment I start seeing less erythroid, I'm already looking at the pronormoblast. I'm already asking, is there a history of immunosuppression? Then I go to the biopsy, I'm looking for these things. They are rare to find, but then doing a good 71 immunostain, identifying only large cells, no mature normoblast. And then I'm looking at, okay, can we do a parvovirus DNA or a parvovirus IgM to look for parvovirus infection in such a case? Next case, again, a child. This is a 3-year-old with pancytopenia, had hepatosplenomegaly, delayed milestones. So my mind is already working. Okay, am I looking at something infiltrative because the liver is enlarged? There's a maybe extramedullary hematopoiesis happening. There's a cytopenia, means infiltration. So at this age, okay, am I looking at something? Is it a leukemia lymphoma? But the delayed milestone is telling me, okay, there's something else happening, a little chronic. And I go in there and we get those classical storage cells. Okay, do not confuse this with the normal histiocytes. Um, I don't have enough experience to separate them from glycogen and Niemann-Pick. I always stick to saying this is a lysosomal storage disorder. And in today's day and age, with NGS and other testing, we can get to what kind of disorders they are with an experienced eye. People who've seen a lot of it can pick with the features between the two, but there are so many variants that you end up relying on the ancillary assays. This is another patient who had a 9-year-old who had fever on and off, bony pains, weakness, since the last 2 months, mild hepatomegaly, and outside CBC reported abnormal cells. A marrow was done, it was packed with blasts. So typically the first thing we see, okay, 80 to 90% blast in a child, we're dealing with an acute leukemia. And the next thing we do is cytochemistry. It comes very, immediately. An MPO, this is the internal control on the MPO, and the blast were MPO negative. So here I always encourage students to say, call this acute leukemia MPO negative. Even in a child, even if it looks lymphoid, this is not ALL. Because an AML can also be MPO negative, especially like an M0 or others subtypes. So here at this moment, it's acute leukemia MPO negative. The provisional report has gone to the physician. He says, please go ahead and do the flow cytometry assay. And typically a flow cytometry assay in our lab, during a working day, it takes around 4 to 8 hours to do, depending whether to do one panel or 2 rounds of panel, and the provisional report goes out on the same day. So what are we looking? We are looking at a set of markers. We typically have a B tube, T tube, myeloid tube in a leukemia. And in this case, the population of interest was blast, which are red in color. These were expressing 10, 34, CD19. They were negative for 20. The myeloid markers like 13, 33 were absent. T markers like 3, 7, 5, 7 were absent. So in the end, we looked at the different markers and we said, okay, this is an acute leukemia. It has presence of B lineage markers. The T and myeloid markers are negative, and this is the classical BLL. So that's how we sort of immediately gave the report. And typically at this moment, the clinician will ask, Let's do the ploidy. Ploidy can be done by cytogenetics or flow, and we do a FISH panel for the common recurrent translocations. And you may now also have the NGS RNA mutations or pH-like panel for FISH translocations. Post this patient was treated, and post-induction marrow is received. Now, at this time, we received this bone marrow, and I'm asked, is this residual disease? On morphology, can you tell me, is it more than 5% blast? Yes, it definitely looks more than 5% because if you do a count only in these 25 cells, they look like blast, they look like medium to large size lymphoid cells. With an experienced eye, I'm saying, if I were to report only the aspirate, I would write, okay, so many percent blast dash hematocones cannot differentiate morphologically. So morphology is useful, but it will not always help because you may have 25-30% hematocones, and the only answer here comes using assay studies. Now, there are cases where aspirate has certain more advantages. There are cases where biopsy has more advantages. There are cases where flow has more advantages, and there will be cases as molecular testing like a BCR label will have more advantage. They are all going hand in hand. You cannot say, I'll do only aspirate and know everything, or only one test will tell you everything. You have to do everything comprehensively. And this is the example to bring to you the problems only to rely on morphology. So here, simply hematocrit would not be an answer. So I need to do MRD in minimal residual disease or measurable residual disease, how it's called now. We don't look only at markers because both the blast and hematocones or abnormal blast and normal blast will express the same markers 10, 20, 19, 34. So we go back to morphology, but morphology and flow. So we look at normal maturation patterns. So the pink is stage 1, the green is stage 2, and blue is stage 3. So we are looking at cells mature from stage 1 to stage 3, which is the mature lymphocyte. So this is also called as a waterfall pattern, for example. So this way we have made patterns. We look for the red cells, are they lying in areas other than normal? So this is the approach which we call the difference from normal approach in flow cytometry. But it needs a lot of experience, a lot of standardization on the machine where we say this population is different from normal and hence is abnormal. So here there was a population, maybe there might be a combination of hematocones and blasts together, or you may find only small blasts which are less than 0.1% or even 0.01%. So that's how we identify, okay, this is a case of minimal residual disease. So just to bring you the example of how marrow and flow goes together. Now, the second last case, this is a 35-year-old male, came with history of fever or, for the last 15 days, bleeding of gums. The clinician is very worried for this patient and says, please, this is an acute emergency. Let me know what this is. And this is one slide or a picture which should be embedded in all our pathologist mind. I would recommend many, and Dr. Sumeet would agree, even hematologists and clinicians should know this image. This is classical abnormal promyelocytes with Fagger cells. This is the diagnosis. This is an emergency. You need to inform the clinician. You need to start the atrotherapy right there. Look for DIC, both on morphology and as well as the laboratory testing. And the test of choice, obviously, you can do an MPO. One can do the flow. But the test of choice here is the FISH test for T1517. Okay. Now, this is where the turnaround time becomes important. You cannot do normal FISH test report, for example, in a lab takes 2 to 3 days, maybe 3 working days. But if I have a FISH for APML, it has to go the same working day, 4 to 8 hours, or at the max the next working day morning. If it's a FISH for Burkitt's lymphoma, I need it the next working day. Okay. A FISH for BLL can wait for 2 to 3 days, but an APML cannot. The clinician needs to know. So that's where working hand in hand with the clinician, having the facility to do a 4-hour, 8-hour interface FISH and giving the result becomes very critical. Coming to the last case, this is straightforward patient, 60-year-old male, came with severe back pain, anemia, abnormal renal functions, had all the crap features. An M band was done, and there was an IgG lambda. This is the IgG band. There's a lambda band, an immunofixation, classical M band. A marrow is done. This is just to show you a frank case of myeloma. It's sheets of plasma cells, even on the aspirate. The plasma cells may look normal in a myeloma. They may look abnormal. You can see binucleate, trinucleate, but keep in mind, every time you see a binucleate plasma cell does not make it abnormal. Even a trinucleate can be seen in a reactive marrow. Reactive marrows can have 5 to 20% plasma cells sometimes. Please look for infections, especially for LD bodies. Look for historyosplenomegaly. Plasma cells may be increased in aplastic anemia. Plasma cells may be increased in association with other lymphomas. For example, in AITL, there is polyclonal hypergammaglobulinemia and increased plasma cells. So, just because you see increased plasma cells, do not jump the gun. But obviously, in this case, M-band positive classical CRAB symptoms, you are dealing with a myeloma. Sometimes plasma cells may start looking funny. This is also called as a flame cell. typically you see in IgA myelomas where the proteins are looking, giving that impression of a flame. And you may see inclusions. Sometimes they're round ball-like inclusions, sometimes they look like ore rods, like in this case. This is one of my examples during my Tata training days, where you have typical ore rod-like cells. These are not ore rods, these are essentially immunoglobulin inclusions presenting in different forms. So plasma cells on aspirate look easier. On biopsy, they are extremely innocuous. I call them the melanoma of bone marrow biopsies, where sometimes without IHCs it become difficult to quantitate, and the quantity of plasma cells become critical because there are certain criterias. More than 60% makes it a myeloma independent of other criteria. So that's where the quantification of plasma cells using CD138 becomes extremely critical. So these are a few examples which we use in day-to-day practice, highlighting the approach. And that's the end of my talk, and I'll be happy to take questions now or later as Dr. Simi decides based on the session. Thank you so much for your patient listening.
Thank you, Kunal, for such an extensive presentation. I think it was very, very critical that we all understand what is it that we need to look at when we are looking at a bone marrow aspirate, the different cell types, and how to differentiate one from the other, especially when you are looking at a case of leukemia and you have done the initial flow cytometry and the case comes to you for MRD. Then it is very, very important, as Kunal said, to understand whether they are hematobones or whether we are looking at blasts. The other important point that Kunal brought up, which is very critical, is when we are looking at a case, it has to be in totality. A bone marrow aspirate, a bone marrow imprint, and a bone marrow biopsy. I think that's a constant tug of war between two departments as to who's going to be reporting what. And somewhere it is, why should I send my slide to hematology and why should hemat slide come to histopathology? I think what we are looking at is at the patient as a whole and not a specimen. I come from a background of a reference lab where I always thought that a sample walking into my lab is actually a patient walking into my lab, because you see less number of patients in a reference lab as compared to the number of samples, unlike Dr. Bhatia, Sumeet Bhatia, who sees more patients because he works in a hospital setup. People like Kunal and me and a few of us who work in a reference lab probably do not see that many. And then the crux of the matter is a clinical connect. And that's what I said. A bidirectional interface is what is the most critical in the area of lab medicine as well as clinician. We will take the questions later on. And I would now go ahead and request Dr. Sumeet to give us his talk. Thanks, Kunal, once again.
Thank you, ma'am.